Good morning, everyone, and welcome to another TIRO seminar where we bring every week new information in the field of thyroid cancer from world-renowned experts. And we are extremely fortunate today to have two of the world-renowned experts who have joined us with the detailed and comprehensive common subject. I'd like to introduce both the speakers. The first speaker is Anton Engelsman from Amsterdam, Netherlands. He is an endocrine surgeon, and interestingly, he is also a clinical epidemiologist. That's a rare combination of surgeon scientists. So welcome, Anton. We look forward to your presentation, and I'm sure your contributions to TIRO will be well remembered. Our discussion today is none other than Eyal Robenshtok, who is well known to TIRO. He's on the TIRO board, and more importantly, his name is synonymous in Israel as thyroid cancer. So his contributions are well recognized. His publications in the field of thyroid cancer are extremely well appreciated and well conceived by everybody involved in the management of thyroid cancer. So Eyal, welcome. I would also like to put a plug for TIRO podcast, the Voices of Wisdom, which started with Janice Pasika and now taken over by Dana Hartel. These are published every third Tuesday of the month, and they are really wonderful presentations from the world leaders in the field of thyroid cancer. The information you will get there in 20 minutes is just mind-boggling. It is practical, it is straightforward management of thyroid cancer, and it is something that we all have questions, but we don't have answers. And it is good to hear to these world experts and get the answers from them. So once again, feel free to join Voices of Wisdom, the podcast. I'd also like to put a plug for our World Congress on Thyroid Cancer from 9th of July to 12th of July in Boston. This is the 4th World Congress, and we had several in between every 2 years. This World Congress will be extremely well received, and the information and the educational value is unparalleled. Many of us are on the board, and most of us are on the faculty, bringing in the contemporary subject of management of thyroid cancer. So do visit Boston from 9th to 12th of July. You will see me there, and I'll be happy to welcome you. Mark, there is a red carpet for you, specially laid down for you. So once again, welcome. Without further ado, I would like to have Anton start with his presentation, and then we'll have Eyal make a comment.
Thank you, Professor Shah, for this kind introduction and having me here to present our work on the definition of differentiated thyroid cancer recurrence. So my name is Anton Engelsman. I'm a consultant surgeon at the Amsterdam Center for Endocrine and Neuroendocrine Tumors, which is within the Amsterdam University Medical Center in the Netherlands. And I'm involved in treating thyroid cancer as a surgeon, but also parathyroid disease, adrenal disease, and neuroendocrine tumors. But today I will discuss our work on the definition of recurrence of differentiated thyroid carcinoma. And although I think this seems a clear-cut situation of recurrence of a cancer type, in daily practice, at least in my opinion, that's quite challenging. So the definition of recurrence is less defined as you may think. So this will make it an interesting topic for a debate, I guess. First, my disclosures. I have no conflicts of interest. Only some financial support that has contributed to this work by the Dutch Pediatric Cancer Fund, which we are very grateful of. So first, one or two slides just to establish some to set the stage. Actually, differentiated thyroid cancer. I think everybody knows the definition of differentiated thyroid cancer, but it's most common type of thyroid cancer and includes papillary and follicular thyroid cancer. It's characterized by cancer cells that resemble normal thyroid cells, and that's beneficial because these cells will also take up iodine, which can be used as a treatment. And overall, it has a very good prognosis with high survival rates. But recurrence is still an important outcome of treatment of thyroid cancer, and maybe even more important since the overall survival rates are high. So what's recurrence then? Recurrence means that the cancer has reappeared after a period of remission following initial treatment, and that's basically a definition that's used commonly in oncology. And remission is a period where there's no evidence of cancer, so that encompasses the time span. And then for thyroid cancer, recurrence can, of course, be local in the neck area or distant in other parts of the body, and mainly in lungs or maybe bones. For the recurrence of differentiated thyroid cancer in clinical practice, a couple of modalities can be used to assess the recurrence. These include biochemical markers, such as thyroglobulin levels with or without thyroglobulin antibodies, but also imaging studies, most commonly neck ultrasound, but also CT or MRI or radioactive iodine scanning. And these are often combined with a form of pathology, most often cytology, to identify the cancer cells through a biopsy. And there is a time span. So when talking about recurrence, it's makes sense to include a time frame of no evidence of disease until there's an actual recurrence. So first, I want to introduce a few clinical situations that illustrate the difficulty when talking about recurrence. This is first case is a pretty straightforward case, I guess. People that work with patients that suffer from thyroid carcinoma might recognize a case like this. Young female with a negative medical history and presented with a neck mass, and with the workup with a neck ultrasound and a fine aspiration, it revealed a thyroid 5 lesion of less than 1 centimeter, but also a lymph node metastasis in level 3 on the right side, which was confirmed with cytology. So quite often these patients will receive a total thyroidectomy and a lymph node dissection of levels 3, 4, and 6, followed by radioactive iodine. Well, we can discuss the doses of iodine, but this is in the Netherlands, this would be the advice. And during the iodine uptake scan, there's no uptake in the neck or elsewhere. And during follow-up, 1 year follow-up showed a negative neck ultrasound, a low thyroglobulin, no antibodies. Well, I did not mention it here, but let's assume no antibodies. So this is the type of case that would be classified as a patient with an excellent response and low rates of recurrence. I think this is a case that will not have a lot of discussions on. But let's change a little bit the situation. And after 1 year of follow-up, there is a measurable thyroglobulin. So now this patient will ask if this means that she has a recurrence or not. So what do we tell this patient? Should we conclude that there is a recurrence, or is it? Do we have other explanations? And there are more of these modalities that can be a little bit different when having these patients in your clinic. For instance, when you have a suspicious lymph node, but which is cytology proven, and there's a little increase in thyroglobulin. Also, this seems to be a clear-cut case where which we would classify as disease recurrence or maybe disease persistence. Let's assume that there was no evidence of disease after 6 months. So also this is a clear-cut case for recurrence. But when the cytology was not proven and the radiologist tells you that he finds or he or she finds that there are suspicious lymph nodes, but after fine needle aspirations you cannot find a cancer cell, but still the thyroglobulin is a little bit elevated. Should we consider this as a recurrence? So these situations again can stir up a lot of discussion in the clinical practice. Also, the issue of thyroglobulin antibodies in the case of negative thyroglobulin levels might blur the conclusions on recurrence. This is yet another situation that's quite illustrative, in my opinion, that when you have a treatment done and on the iodine scanning, the nuclear medicine physician will tell you that there's some physiological uptake in the thyroid bed, but no uptake elsewhere. And after 1 year, there's a small paratracheal mass on ultrasound, and the thyroglobulin is a little bit elevated. Is this a recurrence, or this might be persistent disease, or this might be normal thyroid tissue which was left behind due to a strategic decision from the surgeon, maybe to prevent damage to the recurrent laryngeal nerve. So these are all just examples of cases that that illustrate that it's not so easy to talk about recurrence as a binary outcome. Although I assume we shouldn't worry about too much about all these cases, because the prognosis is still excellent. But now each of these patients will ask us if the cancer is back, and what do we say? And also, when these patients enter a database for instance, quality registry or a study, how would we score this situation in the patient when asked to fill in the yes/no field for recurrence? And I think that's a bit the issue at hand that we have here. Well, generally, when in case of doubt of any well, in case of doubt, as a physician, considering the clinical situation of a patient, we can turn to the guidelines to look for the recommendations and the definitions. So here is a list of some of the guidelines. I think the most important guidelines. But unfortunately, in the case I just mentioned, guidelines are not very helpful to define whether these patients should be classified to have recurrence or not. The American Thyroid Association guideline, and I refer to the guideline of 2015 because the new guideline is not yet formally published. But this guideline does not define recurrence. It does describe and has made efforts to describe disease presence, and also criteria based on biochemical or structural evidence are described, but there's no clear time frame, and these are all described in the context of response to therapy. The European Thyroid Association guideline provides no explicit definition of recurrence as well. It defines complete remission, but only after total thyroidectomy and radioactive iodine treatment. The Latin American Thyroid Society and the Asia-Oceanic Thyroid Association both do not provide any definition on recurrence. And interestingly, when looking at these definitions, they are all in the context of a total thyroidectomy and radioactive iodine. So in an era where we are de-escalating surgical treatment or treatment for thyroid cancer, and lobectomy, hemithyroidectomy, subtotal thyroidectomy is more common, these definitions do not apply. So why is a universal definition of recurrence needed so much? why should we bother to define thyroid cancer recurrence at all? It's in the clinical practice, it might be more appropriate to talk about response to treatment. But still, when you want to talk about prognosis, recurrence is one of the most important outcomes to consider. And the current lack of consensus limits comparability of studies and study outcomes, and limits also consistency in the guidelines. And I think that might be a big issue. Therefore, a universal definition of recurrence of differentiated thyroid cancer is essential, I think, and it would improve clinical decision making based on clear outcomes, and it will also improve consistency in research. But why is it so difficult to establish a definition of recurrence? And as I have showed, I think with the case examples, it is difficult to establish clear definitions for recurrence for differentiated thyroid cancer based on the factors such as heterogeneity in disease presentation and also disease behavior. Differences in surgical approaches to treat the disease, but also the long-lasting effect of iodine on the thyroid cells. So some evidence of persistence might not be real persistence disease, but also the specificity of the available biomarkers. Thyroglobulin, as you well know, is not very specific for thyroid cancer, but is also specific for normal thyroid tissue. And there are differences in assays and imaging protocols and imaging quality that all might impair the different modalities that add up to decide on whether there is a recurrence or not. So how should we address this issue to get more consistency? We decided on doing a systematic review to map and analyze how current worldwide definitions are structured at the moment. And so that would be the first step. And from this review, we can identify some factors that are included in a definition. And these can be used to in a Delphi process. So in a Delphi process with global experts who can evaluate and refine the components for the definition. And the aim is to establish a minimal essential criteria for universal definition of recurrence for differentiated thyroid cancer as a foundational framework. So then the third step would be to use these results from the review and the Delphi as some groundwork to guide for a future development of a final consensus-based universal definition. The study that I'm going to present more here now is the first step, basically representing the first step, the systematic review we've done. This study was published last year in November in Thyroid, and which we are very happy about. And the study group encompassed quite a broad spectrum of researchers and clinicians. Representing all types of specialties, so not only surgeons but also nuclear physicians and endocrinologists over different university medical centers in the Netherlands. And the aim of this study was followed from the issue that we encountered to delineate the definitions of recurrence of differentiated thyroid cancer and to categorize them by total thyroidectomy with radioactive iodine, total thyroidectomy without radioactive iodine, and lobectomy. So we could assess if there's a generally accepted definition among these categories, and if not, what kind of components would be most commonly used to describe recurrence. For the methodology, we followed the PRISMA guidelines. So those are the preferred reporting items for systematic reviews. that provides a very standardized way to take up the endeavor of a systematic review. The study is registered in Prospero, and we did a systematic search based on an exact search query that I will not present here, but you can find that in the supplementary data from the publication. And we did a systematic search in Medline and Embase. We focused on studies published between January 2018 and December 2023. The reason for that, not to go further into history, is that we thought it would be less relevant to include definitions that were used earlier. So we focused on the most recent definitions to have a better match with the current clinical practice. We had some in- and exclusion criteria. We included all studies regarding differentiated thyroid cancer. These studies should report on recurrence following initial treatment. And we did not exclude any age, so pediatric and also adult populations were included. We also had some exclusion criteria, some obvious, such as other types of thyroid cancer, such as anaplastic thyroid cancer, medullary thyroid cancer, were not included into this meta-analysis. But also NIFT-P was excluded as we consider that as a non-malignant disease. Now, the important thing is to recognize that there should not be mixed cancer types within one population, because that might have influenced recurrences or also definitions of recurrence. So it should be one type of cancer per population, and that also goes for the treatment. Since we wanted to certify per treatment type, we only included studies that reported on one single treatment per study group. And non-surgical treatment for differentiated thyroid cancer was not considered as an initial treatment. For example, active surveillance or ablation techniques were excluded from this meta-analysis. This is the Prisma flowchart, which shows the results from the study query in PubMed or in Medline and Embase. This resulted in over 2,000 hits, and after removal of duplicates and screening for title and abstract, there were almost 500 studies that were potentially eligible. And of those, the majority was again excluded based on the in- and exclusion criteria, and we ended up with 70 studies that matched the inclusion and exclusion criteria and were included for the review. The data extraction was followed also quite a formal protocol. There were 2 independent reviewers involved as authors in this article that independently processed all the studies and also processed the data extraction. They used a predefined data extraction form to minimize any heterogeneity in the data. And in case of any disagreement, a third reviewer was asked to resolve the disagreement. So a process like this helps in maintaining homogeneity in the data and interpretation of the data. So then to the results. As I mentioned, we identified 70 studies, and those were included in the analysis. Of these 70 studies, 49 reported on recurrence after total thyroidectomy and radioactive iodine treatment. Only 4 studies reported on total thyroidectomy without any radioactive iodine treatment, and 17 studies reported on hemithyroidectomy as an initial treatment for differentiated thyroid cancer. Especially the first and the last one, I think, are most clinically relevant in this case. Out of these studies, basically 4 components were used in describing recurrence per study. So every study has its own definition for recurrence written in the methodology. And these are the 4 components that came up. These consisted of pathology confirmation of the recurrence, of imaging studies that confirmed recurrence, thyroglobulin levels, and also a tumor-free time span. And interestingly, most of the studies, 44 out of the 70, used some sort of pathology confirmation, quite often in combination with imaging studies, obviously. But also interesting is that only 9 studies out of the 70 introduced or defined a tumor-free time span in the context of defining recurrence. So that might be already a sign that there's a lot of heterogeneity here. Please note that the numbers of these studies don't add up to 70 because some studies used a combination of components to define the recurrence of differentiated thyroid cancer. So let's look first at the patients that received a total thyroidectomy, or the studies that reported on the outcomes of a total thyroidectomy followed by radioactive iodine for differentiated thyroid cancer. As you see, the table here that provides all the different definitions that we found is quite large. And that at itself already is a sign that there's a lot of heterogeneity. Also, there's no single definition or single combination of modalities for a definition that stood out to really provide some guidance into how we should define recurrence after differentiated thyroid cancer treatment. Most commonly, there were multiple diagnostic modalities involved in the definition of recurrence, and of these, imaging studies in combination with pathology-proven recurrence were most common. But this was only in 22% of the studies. So 11 studies of the 49 used this as a combination. So this shows a lot of heterogeneity to define recurrence after total thyroidectomy and radioactive iodine. Also interesting that the tumor-free time span, which is marked here with the 4C, only a couple of studies introduced that in their definition when describing a definition or providing a definition for recurrence. So these are the results for the studies that reported on total thyroidectomy alone. Only 4 studies, so limited data. Interestingly, every study used a different definition for recurrence. So there's absolute no consensus on or consistency in how recurrence was described for these category of patients. Then for the studies that reported on hemithyroidectomy as an initial treatment for differentiated thyroid cancer, we all feel also in clinical practice that thyroglobulin might not be as sensitive because there are still thyroid left, and that's also reflected in the definitions that we found. Almost the majority of studies that reported on recurrence defined it with a combination, or at least one of imaging studies and cytology or pathology-proven recurrence. So either imaging studies were not described, or it was in combination with cytology or pathology, and that was really the majority of the studies. So there seems to be some consistency here. As you can see, thyroglobulin is not given in any of the studies as a component for the definition of recurrence. So in conclusion, from our meta-analysis, we found no universal definition of differentiated thyroid cancer recurrence across any of the treatment categories. Of the 70 studies resulted in 20 different types of definitions used in all these studies. And the majority of these definitions concerning recurrence and complete remissions in international guidelines primarily center around the treatment involving total thyroidectomy and radioactive iodine. So that makes it difficult to apply on patients that received another treatment than this. We did identify some components, imaging, pathology, biomarkers, and tumor-free time span, and these could lead to sorry, Eyal, I'm continuing a few slides still. And these components can be used for our second step, in which the Delphi process will be used to get a global expert-based consensus on defining recurrence. We have actually already started this Delphi process and performed it somewhere last year. The Delphi method gives you a structured input from predefined panel of global experts, and that gives a over multiple rounds. So after the first round, we could add or change some of the statements, but after the first round only. But after the other rounds, we did not change anything to really have a reliance on the expert consensus of these statements, and to minimize bias. The study design consisted of a steering committee of a number of thyroid cancer experts from various specialties in the universe, also from various universal medical centers in the Netherlands. And they supervised the study protocol and advised on the round results and design, but not participated in the Delphi scoring process. And the Delphi participants were invited through the major thyroid societies around the world, and were identified through the major guideline authors and also last authors of systematic reviews. And this provided a very diverse and diverse group of experts from across different disciplines and different continents, with clinical and research involvement in differentiated thyroid cancer. Very representative. The 127 respondents completed all 3 rounds, and those were from 35 countries all over the world. And very briefly, these are the initial results. This study is now under review or under a revision for a thyroid. So hopefully we can provide this publication as well. But we came up with a consensus-based definition of recurrence after total thyroidectomy, after treatment with total thyroidectomy and radioactive iodine, which included a definition of complete remission, but also which is needed to define recurrence. And also we were able to find consensus on a definition of less than total or hemithyroidectomy, because that's a bit of the issue that we encounter in the guidelines. And also here, complete remission is important, and recurrence was defined without thyroglobulin. So my final conclusions, the International Delphi consensus identified essential components forming a foundation for universal definitions of differentiated thyroid cancer recurrence. And the standardized definitions will improve consistency in clinical practice and also enable comparable high-quality research globally. And the adoption of these definitions, I think it's crucial for advancing patient care and science progress in differentiated thyroid cancer. I would very much like to thank you and the THANC Foundation for inviting me, and I'm looking forward to answer any questions.
Thank you very much, Professor Engelsman. That was wonderful. And we're very happy that you not only presented the paper you published in Thyroid, but also gave some uh, pre-publication information about your Delphi study. I think that is wonderful, And I have a feeling once your paper gets published on Delphi, there will be more confusion than resolving the issues. I think the two subjects in thyroid surgery, which are quite confusing, number one, as you mentioned about recurrence, and the second, post-operative hypoparathyroidism. I still not been able to tell what is truly hypoparathyroidism. Is it my imagination? Is it patient's conception? Is the patient coming back to the emergency room? I don't know. I think that will be a subject of another discussion. So without further ado, I would like to invite Professor Robenshtok from Israel, who is a true clinical scientist and has done remarkable work. If you have time, look at his publications. They are really practical publications and a wonderful study. So Eyal, please go ahead.
Thank you, Ashok, for this wonderful introduction. I just want to say I'm in Israel now. I just got a notice that there are going to be sirens soon. So hopefully I'll get through this short presentation. So this is a 10-minute presentation just to highlight why it's so difficult to define and know exactly who has recurrence and who doesn't. And we'll go over two cases. So this is Josh. He's 26 years old. In 2021, had total thyroidectomy and right central neck dissection. On pathology, he had a small 1.6 centimeter PTC with 5 involved lymph nodes up to 0.9 centimeters and was treated with radioiodine, and the whole body scan was normal. And he was followed at a low volume hospital. Wait a minute, you'll see why I'm mentioning it. And he had a normal ultrasound, undetected thyroglobulin, normal antibodies, and was defined as excellent response to therapy, and everyone were happy. And then a year later, he moved to the big city, and then he went to see specialists in a large, high volume hospital. And an ultrasound, he had a right level 3 suspicious lymph node, 0.4 over 1 centimeter. Now the question, is this new, or is it just a different or a better sonographer? And people who treat thyroid cancer see this phenomena all the time. Someone has nothing, and then they go to the best sonographer, and then you find a suspicious finding. And how common is it? So in 2020, there was a really nice study published in the American Surgeon, and they looked at surgeon-performed ultrasound, people who are very experienced in doing neck ultrasound. And in 29% of cases, that's a lot, the surgeon find new suspicious central or lateral neck findings not reported in the referral ultrasound. So the first problem that we have, which is really common all over the world, is the quality of the ultrasound. One examiner will find the disease or suspicious finding, and another one will not. Now, when we see a lymph node in the neck, it can be benign, look benign, it can be non-specific, or it can be suspicious. So again, it's not black or white. On the top here, you see a benign lymph node. Below that, on the left, you see clearly suspicious lymph nodes, but on the right, on the upper right lymph node, you see a lymph node with no hilum. It can be benign, it can be cancer, it's non-specific. So what do you do with that? It's not black and white. Well, if you do a study and you have this patient, how do you report this outcome? As good or not? Now, this patient was treated with radioiodine. Many times, you have these lymph nodes that are non-specific, and they were treated with radioiodine, and they can live their whole lives with without any consequence because maybe this lymph node was treated. And if we do an FNA, we can find the recurrence. If we don't do FNA, we can get used to it, see it every time on an ultrasound, don't think much about it. And then if we do a study, it won't be defined as recurrence. And specifically, this lymph node is from a study about autoimmune thyroiditis. So this is just a reactive lymph node, but easily, if we do an FNA, it can easily also be a metastatic lymph node. Now, another question. Let's say this was, we did an FNA and we find papillary thyroid cancer cells. This patient was treated with radioiodine. And many times we see patients who have metastatic lymph nodes. They are treated with radioiodine. Most of the time, these lymph nodes don't disappear. Many times, they just stay there and they're stable over years. But still, if you do an FNA, you're going to find thyroid cancer cells. If we do a thyroglobulin washout, thyroglobulin is going to be high, but still it was treated by radioiodine, and many of these lymph nodes will be stable forever. So maybe it's not that simple to call it recurrence or not recurrence because it's more, you have all these options. It can be recurrence without growth due to radioiodine treatment or just the natural history of the disease. Okay, and now we have sirens. So unfortunately, I have to leave. So Ashok,
Yeah,
I'll just take you to the last slide with all the questions, and I'll be back in about 10 minutes.
no problem, Eyal. Be safe, be careful,
Yeah.
and we are with you and your family.
Okay.
If you cannot come back, don't worry. I understand that. No problem.
Yeah, okay.
Okay.
Bye.
Even though Eyal spoke for a short time, and I understand the political situation, we appreciate his coming on, and it is the whole world is in distress right now. So I don't want to go in the details, but I think we're always concerned, and we wish the very best to Eyal. Let's explore some of the ideas from Anton. Anton, there are a couple of questions on the website, and I would like to start with those, and then I'll bring my own questions. Dr. Smith asked the question about the timing of RAI. Is there any critical time when the RAI should be given? For squamous cell carcinoma, when we give post-op radiation therapy, we talk about 6 weeks, 8 weeks. Is there a timeline for thyroid cancer as to when to give, and what's the impact of that on either recurrence or mortality?
Yeah, that's an excellent question. I think it's really clinically driven, this question, and I recognize the issue as well in my own practice, that sometimes a patient asks me, is it really necessary to have the iodine already, or can we postpone it to after pregnancy or whatever? So the review we did really focused on identifying components that should be used in the definition of recurrence, but did not really look at the consequences of treatment options. So that's more or less a clinical issue to look into the timing of the iodine. So from my personal experience, I think I'm quite liberal actually in planning the iodine.
Yeah.
I recognize that there's a bit of a movement away from iodine. So we already lost, the nuclear medicines physicians lost indications for the small thyroid cancers. And now in the new guidelines, new Dutch guideline, also in the ATA guideline will come up. Even larger thyroid cancers, but without any invasive pathology findings, you might consider not to give iodine. Last year, a few very nice studies, although retrospective, but with propensity scored matching, on patients with intermediate risk thyroid cancer and also with lateral neck involvement. Showed absolutely no evidence of any beneficial effect of iodine on recurrence and on overall survival. So I think it's a very interesting debate on iodine timing, but also on efficacy in patients. And I might wonder that when we have a discussion like this in 10 years from now, if the role of iodine has even been less than it is now.
Very well said, Anton. And I'm very happy that you summarize the current philosophy and paradigm shift that we have seen in last 2 decades in the United States with the use of RAI. And
Yeah.
it's quite interesting that even in our institution at Sloan Kettering, we are going far away from the routine use of radioactive iodine. We use that very selectively. Also, I think we are putting in perspective the complications of RAI.
Yeah.
Which we didn't think in the past, the chronic sialadenitis, development of second primaries, etc. We didn't have the good data. We didn't follow them very closely. And there was a kind of big gap between the patient, the surgeon, and the endocrinologist. Now, I think we all make a combined decision rather than just making a unilateral decision. So I think your information is very interesting. Actually, it is very interesting if you look at the paradigm shift about doing the preoperative CT scan. At one time, that was frowned upon to do the CT with contrast because you're going to delay the radioactive iodine.
Yeah.
But the information you get from the CT is so critical for a surgeon to make appropriate decisions and get the better outcome. I think that is a very clear-cut information that is available now, that the timing of radioactive iodine really does not matter much. Actually, in young college kids, we delay the radioactive iodine till they have their summer vacation or the time which is the best timing so that they don't lose the semester from the college. Now, if we were to be so strict, we would have done that much earlier. We don't do that. The other thing is with Thyrogen, if you really want to give it in 3-4 weeks, it's not a problem. We can do that. So again, some of these, I don't think we'll ever be able to get a full answer on that. Let me ask you another question, Anton. There is a question from Dr. Nair that they find the rising thyroglobulin, but no structural disease. Now, this is what brings me to ask you a question. Is there a difference between biochemical supposed recurrence and the structural recurrence? And what do we tell the patient? Go ahead, Anton.
This is again extremely interesting, and I think you will get different answers when you ask different physicians. So when you ask a surgeon, the surgeon will focus on structural disease because that's also something he or she can solve. When you ask an endocrinologist who does the follow-up on this patient, they will be more aggressive in defining whether there's a recurrence based on biochemical markers. I think there's so much to the sensitivity of thyroglobulin. It's not specific to thyroid cancer. So you really have to assess thyroglobulin, I think, in the context of different modalities, such as structural disease. If you don't have any structural disease, when I have a patient with no evidence of structural disease, a little bit of rise in the thyroglobulin levels, I'm doing nothing. I just wait and see. And it becomes even worse, actually, because now in the Netherlands, we also have high sensitive thyroglobulin. So we don't have a lower boundary of 1.4 or 1.0 nanogram per milliliter. But now we can measure every number after the comma, after the digit. And now you will get a thyroglobulin level result that rises from 0.2 to 0.4, and the patient asks, what's happening here? So basically, that's information I don't want to know.
Yeah. I think that's an excellent answer and a good summation of the subject that we are discussing today. The way I look at the thyroglobulin is the trending. What has
Yes.
happened to the thyroglobulin 6 months from today? If it is slightly elevated today, I'm not going to be bothered with that. But if there is a major jump in 6 months or 2 years, the one good thing about thyroid cancer is even the recurrent thyroid cancer, it's a chronic disease. So whether you make a diagnosis today or 6 months from today, unless there is an obvious structural disease, I'm not terribly concerned about it. I don't see any evidence that the survival has changed or the morbidity, mortality has changed because we waited for 6 months or a year. What do you think, Anton?
Yeah, I totally agree. So when you see a rise in thyroglobulin levels, I'm not, and no structural disease, I'm not so concerned about overall survival. But I do think I'm a little bit worried in a case like that, that there is a higher chance that you will find structural disease somewhere down the timeline. But before you have that, I would refrain from any therapy, actually.
Remember, there was a time when I was in training, there was only one way we found the structural disease. That was clinical examination.
Yeah.
We didn't have
Maybe that
any
was
other
better than now.
and clearly, I think we have changed our paradigm quite a
Yeah.
bit by
Yeah.
doing the ultrasound. And I think, as Eyal mentioned, I completely agree with him. It does matter who does the ultrasound.
Yes.
And every patient who comes for thyroid surgery at our institution, irrespective of previous ultrasound done in a major university center, we repeat the ultrasound. Number one, we want our own baseline. And number two, we will be able to get a better sense about the extent of the disease. I would like to add one more point here. We do generously use CT scan with contrast preoperatively. It gives us better information about the paratracheal lymph nodes, the superior mediastinal lymph nodes, the level 2 lymph nodes, which may be very difficult for the ultrasonographer to point to. So again, this is our personal philosophy. The larger the tumor, more the information you will get from CT scan. Any comments about this, Anton, about the CT scan preoperative?
Yeah, I actually totally agree with you that we quite often have this discussion. We have a radiologist that's very experienced in head and neck ultrasound, um, uh, but still there are areas in the neck that are not well scanned, basically with an ultrasound. So I will not do a CT scan in every patient, but when there is some evidence of larger extent of lymph node involvement, or when there's, for instance, major vascular invasion, I will do an MRI or an ultrasound to be informed as a surgeon on the extent of the disease. It will give me far more information on how to plan the surgery. And in the Netherlands, it's a bit different maybe than in the United States, but as surgeons, we do not perform our own ultrasounds. We send those patients to a radiologist. So that's a bit of a different way of working. So I can do an ultrasound, but I'm not so experienced. So I will not do an ultrasound before surgery. I rather would look at some anatomical scanning.
You said it well. There is no doubt about that. I want to bring up one other interesting point. And this is more philosophical. When you see the patient on day one, even before all imaging and surgery, we know who is going to do well and who is not going to do well. A patient with paralyzed vocal cord or the patient with bulky nodal disease, we know deep in our heart he's not going to do well for a long time. Post-operatively, I think we will get better sense. How did the surgery go? And who is the best analyzer of this? The surgeon himself. Because they can tell this surgery was very difficult. The tumor was stuck to the cricoid cartilage. The future recurrence is going to be very difficult to handle. So I think that information, somehow or the other, does not get into the medical records. And I think that information is very critical. Mark Erkan wrote a paper recently with some collaborators, including myself and Mike Tuttle, which was published in the European Thyroid Journal, about the conveying this message about the aggressiveness of the tumor to the pathologist, to our colleagues, to our endocrinologists, and the patient himself. So I think that information is very important. I just want to add one more thing. Let's say, hypothetically, a patient has 10 positive nodes. We know deep in our heart, no matter how good a surgery you do, there is a 11th node missing somewhere in the neck, which will cause rising thyroglobulin over a period of time. I don't know what is the period of time. We use that word very casually, over a period of time. Is it 6 months? Is it 6 years? Or is it 60 years? I don't know that. But we know deep in our heart that this patient with 10 positive nodes, there is a 11th node, and one day when it becomes structurally apparent, the sonographer will find it. Is that the recurrence that happened 2 years afterwards, or this is the same disease that the surgeon was not able to find because it was too microscopic? Any comments, Anton?
I think, well, your last comment was philosophical. I think this is also a little almost philosophical on how would you define curation or curative surgery? When you discuss a patient with a pancreatic carcinoma and you discuss resection with the Whipple's procedure, and then say you will receive curative treatment, well, that's a bit of a misunderstanding maybe to the patient, because this patient will die from his disease. It's a bit of the same with these extended neck involvement, I guess. And what we should distinguish maybe in this situation is whether we would want to know or define in the context of doing research and having our outcomes straight and comparable, or if we are assessing in the context of advising a patient on prognosis and stuff like that. Then from a research perspective, I think you should be more punctual. And it's difficult to assess whether this is recurrence disease or whether it's persistent disease. Well, the thyroid cancer cell in this lymph node has to be there from the start. But from a clinical perspective, I would not rush too much. These are the patients that will have a chronic condition of their disease, basically. They will show you recurrences during a 10-year time period more often. And when your reflex is to treat every proven recurrence, every small lymph node with another neck dissection or a lymph node picking, they will end up doing a treatment every year. And I think that's bad for the patient. It does not influence the overall prognosis. And I think in my practice, we try to postpone any treatment to see how it develops, to see if anything else will come up, and then try to aim for 1 or 2 treatments in 10 years' time instead of 10 treatments in 10 years' time.
Very well said, Anton. I have a philosophy. Don't do second, third, and fourth operation. Try to consolidate to one concrete operation when it is necessary. Now, it becomes somewhat difficult. There is a 1 centimeter node to tell the patient and the family there is a recurrence or not. And I and even our whole endocrine group at Memorial try to avoid a needle biopsy.
Ah, yeah. That's a good
Unless
idea.
the node is in the paratracheal area that I'm worried about, it's going to be plastered against the trachea, we try to avoid the needle biopsy. Because the minute you do the needle biopsy, next day you get a call from the family, when is the surgery going to be done?
Yeah.
So I think we need to prepare ourselves as to how I'm going to manage this 1 centimeter node. Before we go on, there is one question in the chat box. I want to bring it up and I will answer on behalf of the whole group. The question is, what is the risk of recurrence in Hurthle cell carcinoma? Is it low or is it high? I'll make it very simple, and Anton, you make comments on that. We like to divide a Hurthle cell carcinoma into 2 groups. Minimally invasive, where there is minor capsular invasion or maybe one focus or two foci of vascular invasion as compared to widely invasive. The widely invasive is a large tumor, major vascular invasion. It's the same philosophy as the follicular thyroid carcinoma. The widely invasive, there is a higher risk of recurrence and distant metastasis. In the low risk group, the risk of recurrence is very low. Any comments, Anton, on this?
No, I recognize this and totally agree with what you are saying. There are these Hartle cell carcinomas that just look bad, and they're you know how they look, and then there's a high risk of recurrence. And actually, I like your comparison with the follicular carcinomas because it's exactly the same, and we have seen that in our groups as well, where there's a large pediatric population with follicular thyroid cancer, minimally invasive. They never recur. They will not show any lymph node metastasis. You do a thyroidectomy and then it's done. It was quite of a paradigm shift there as well, because these patients were formerly treated all with iodine and total thyroidectomy. But I agree with
Very
Hurtle
much,
cells as
Anton.
well.
That was a great discussion. Again, thank you very much to the audience. I would like to plug in for the next TIRO seminar on next Friday, 27th of June, with Louis Davis and David Francis. Louis is a wonderful speaker, a huge clinical work, and she was the first person who wrote a landmark paper on the incidence of thyroid cancer in the United States, some maybe 15 years back. So tune in to Louis, and also don't forget to tune in to our TIRO podcast. You will enjoy them. I have heard them several times, and those are just wonderful. And I'll be looking forward to seeing you in Boston. So have a wonderful day, rest of the week, and I do wish Eyal is safe along with his family. Thank you very much.